Hydrothermal duodenal mucosal resurfacing, DMR, a novel procedural therapy for metabolic disease. We are investigating hydrothermal duodenal mucosal resurfacing, or DMR, as a potential transoral procedure to improve metabolic health. Hydrothermal DMR is designed to rejuvenate the duodenal surface in patients with metabolic diseases such as type 2 diabetes. The rationale for this approach comes from our knowledge that nutrient bypass from the proximal intestine has known metabolic benefits, and that the upper GI tracts of diabetics display abnormal hypertrophy and abnormalities in enteroendocrine cells. Revita DMR is a catheter-based upper endoscopic procedure that uses a combination of circumferential mucosal lift and hydrothermal ablation to engender rejuvenative healing of the duodenal mucosa, along with a consequent beneficial alteration of gut signaling. The procedure is performed using novel single-use balloon catheters. The balloons on each catheter are approximately 3 centimeters long. The first catheter is used to size the duodenum and lift the mucosa from the underlying muscularis with saline. A second catheter is used to perform hydrothermal ablation of the mucosa. Under direct endoscopic visualization, discrete circumferential hydrothermal ablations, lasting approximately 10 seconds each, are applied at temperatures of approximately 90 degrees Celsius, with the goal of obtaining 3 longitudinally separated ablations along the length of the postpapillary duodenum. The procedure is monitored and controlled by the physician from a standalone console. The patient in this case is a 43-year-old male with a 6-year history of type 2 diabetes. The patient had poor blood sugar control on oral anti-diabetic medications and was enrolled in a first-in-human clinical trial testing the hydrothermal DMR procedure. With the patient under general anesthesia, we perform a standard examination of the duodenum using a PCF endoscope. We then inject black ink approximately 1 centimeter beyond the papilla as a landmark for beginning the DMR procedure. We next deliver a standard endoscopic guide wire through the endoscope into the jejunum and withdraw the endoscope. We advance the first DMR catheter over the wire into the duodenum with fluoroscopic guidance. Using this first catheter, we measure the duodenal diameter at D4, D3, and D2 using an algorithm based on a known relationship between balloon pressure, volume, and diameter. These measurements are used to select the size of the balloon for the second DMR catheter. We then position the first catheter at the black ink landmark to begin a series of circumferential mucosal lifts. We follow the first catheter with a PCF endoscope to provide direct visualization. The first DMR catheter has 3 ports spaced 120 degrees apart on the exterior of the balloon, and these ports oppose the wall when the balloon is inflated. Suction is applied to pull mucosa into the ports, and a needle is advanced into the submucosal space. By injecting saline at 3 locations, we obtain a circumferential mucosal lift. Methylene blue dye is used in the saline to aid in visualization. We repeat this lifting process several times along the duodenum, from the ink mark to the ligament of Treitz. As we assess the duodenum, we see well-lifted tissue along the length of the region to be treated. We have injected more than 200 milliliters of saline into the submucosa to extend the longevity of the lift, much as a fuller bathtub takes a longer time to empty. After assessing the mucosal lifts, we withdraw the first DMR catheter, leaving the guide wire in place. We then advance the second DMR catheter over the guide wire under fluoroscopic guidance. Once the catheter is in place in the duodenum, we follow the catheter with the endoscope for visualization. We place the catheter in the proximal portion of the lifted region and activate the hydrothermal ablation function on the console. As shown in this endoscopic video taken through the balloon, we can see whitening of the mucosa associated with thermal or coagulative necrosis. We advance the catheter so that the proximal edge of the balloon is aligned with the distal edge of the previously ablated region and repeat the ablation function on the console. We repeat this process until at least 10 centimeters of duodenum is treated. We then assess the treated region endoscopically and see the whitened mucosa. Coagulative necrosis prevents bleeding, and this tissue will slough over the next few days. By using mucosal lifting and controlling ablation parameters, thermal damage is limited to superficial layers of the duodenal mucosa, where there are no nerve endings, so that the ablation itself does not appear to cause pain. The catheter is then withdrawn, and the patient recovers per standard procedure. At 90 days, follow-up endoscopy showed full healing and a normal-looking mucosa in this patient, and we expect no further mucosal changes. At the 6-month follow-up, laboratory changes in glycemic values show that this patient experienced improvements in metabolic control after the DMR procedure. 6 months post-procedure, the patient's glycated hemoglobin, or HbA1c, fell by 2.3%, from 9.5% at screening to 7.2% at 6 months. Fasting plasma glucose dropped by 30 mg per deciliter, from 162 mg per deciliter to 132 mg per deciliter during the same time period. Alanine transaminase levels, which were followed as a safety signal, remained within the normal range. Hydrothermal DMR does not involve any implants, sutures, or surgery. It is a minimally invasive endoscopic procedure with a procedure time of approximately 60 minutes. We conclude that hydrothermal DMR may provide the ability to improve hyperglycemia in type 2 diabetes and may offer a novel, non-pharmacological treatment for metabolic disease. Further study is needed to evaluate the long-term safety, efficacy, and durability of this procedure.